Hello, and welcome to another chapter of Pediatric Primary Care. Today we're discussing Chapter 23, Prescribing Traditional and Complementary Therapies. This chapter is designed to strengthen the primary care provider's understanding of prescribing pharmaceutical in pediatrics, including ways to enhance adherence and recognize opportunities for primary care to safely support families who desire complementary and integrative therapies. Primary care providers should consult a comprehensive pediatric drug reference, the U.S. Food and Drug Administration, or pharmaceutical manufacturers regarding specific drugs, their classifications, preparations, indications, dosing, side effects, interactions, and other considerations. The National Safety Goals regarding prescribing medications. The Joint Commission publishes national patient safety goals that address several concerns regarding medication practices in ambulatory healthcare clinics and hospitals. Since 2014, these goals stress the importance of reconciling medication information. The NPSGs for ambulatory healthcare clinics, effective January 2022, explain that the comparison made in medication reconciliation addressed duplications, omissions, and interactions, and the need to continue current medications. Important information to be obtained from the patient and caregiver in the ambulatory setting include the medication name, dose, route, frequency, and purpose. This information is important when prescribing new medications, as potential interactions between medications must be considered. The Joint Commission directs healthcare providers to provide written information regarding the medications the patient should be taking, including the name, dose, route, frequency, and purpose, at the conclusion of each care episode. In addition, primary care providers should provide information to patients and families about how to manage medications during each episode of care. Healthcare providers can support this management strategy by suggesting that the family maintain a medication list, up to date as needed, and shared with their primary care physician during each visit. Regulation and safety of pharmaceuticals. Pharmaceutical labeling is required to provide drug information that is easily accessible and comprehensive for providers. The most important prescribing information about the benefits and risk of the drug, the date of the initial product approval, and the phone number and website address to report adverse effects are placed at the beginning of prescribing information and package inserts in the section called Highlights. Similar formatting must be included in the electronic prescribing tool and other information resources. The Pediatric Advisory Committee, or PAC, of the FDA is responsible for identifying pediatric therapeutics and devising research priorities, considering recommendations related to ethics, and evaluating the design and analysis of pediatric clinical trials. An additional role of the PAC is to recommend actions of the FDA to take regarding pediatric adverse events reporting, including warnings about suicide, neonatal withdrawal and toxicity, and risk of off-label drug use. In recent years, the PAC recommended change to pharmaceutical labels, prescribing warnings, and boxed warnings. Many adverse effects of drugs in pediatric patients may go unreported. However, the true nature of the drug's safety may not be fully understood. In the EU, the European Medicines Agency has the responsibility to promote evidence and appropriate availability of medications for pediatric patients. In 2020, the EMA updated the 5 key areas of their action plan to include the identification of pediatric medical needs, strengthening cooperation between decision makers, timely completion of pediatric investigation plans, improved handling of pediatric investigation plan applications, and increased transparency around pediatric medicines. Supply issued with pharmaceutical manufacturers. There are several threats to the global pharmaceutical supply chain, including natural disasters, global pandemics, and manufacturing and quality problems. This is exacerbated by an over reliance on China and India for active pharmaceutical ingredients, with an estimated 80% of the world's supply coming from China, India, and other foreign countries. The status of drug shortages is monitored by the FDA. It's important that primary care providers recognize the risk of reducing price medications on the internet that are available for sale direct to consumers and counsel pediatric patients and caregivers about the added risk to support their ability to obtain safe, high quality medications from reputable pharmacy outlets. General prescribing guidelines. Pediatric patients require unique considerations for medication management. It is critical that the primary care physician resists pressure from the parents or other individuals to prescribe medications without a clear indication. A comprehensive understanding of over the counter and prescription medication indications, contraindications, dosages, adverse reactions, and drug interactions, as well as knowledge of pharmacodynamics and pharmacokinetics of the drug in the developing pediatric patient, is essential for effective medication management. Some general points to keep in mind when prescribing drugs or recommending over the counter medications would include assessing the renal and hepatic system for the degree of maturation and function, the use of clinical practice guidelines when available. Be aware of the influence of advertising on prescribing practices. Use of decision support system to investigate the possibility of drug interactions and side effects. And finally, check for interactions between pharmacologic agents and any herbs, botanicals, or dietary supplements being used concurrently. Prescribing medications in pediatrics. In the past, the dosage for pediatric patients was typically determined by extrapolating from the adult dose and proportionately reducing the dose based on the weight and drug side effect profiles. However, this approach does not consider developmental changes in pediatric metabolism, the drug's pharmacokinetics adverse effects, and the potential suicide risk in adolescence, the medication delivery form. As pediatric patients mature, they are psychologically dynamic. Factors such as size, age, renal function, cardiac output, hepatic blood flow, concomitant drug use, disease, individual characteristics such as ethnicity and genetics, and maturation development of the body system can lead to specific pharmacokinetic differences, all of which can affect any given drug effect and dosing decision. Additional information regarding the unique response to medication based on underlying genetic factors, called pharmacogenomics, is a rapidly developing field that can also inform the guide prescribing practices. Guidelines for clinical pharmacogenetics implementation consortium have been published to support the effective treatment of patients. An example of pharmacogenomics is the awareness of phase 1 enzymes are involved in the biotransformation of more than 75% of prescription drugs, making variations in these enzymes clinically relevant as blood levels may be significantly affected. Key fundamental principles to consider when prescribing medications in pediatrics are drug absorption. The absorption rate of medication administered through subcutaneous or intramuscular injection is affected by blood flow to those tissues, where poor blood flow can result in a delayed or reduced absorption. The immature GI tract of neonates and young infants also influences the absorption of medication through decreased acid secretion, prolonged emptying, lower GI enzyme activity, and irregular peristalsis. Finally, the thin stratum in infants and children, variable hydration, and high permeability of newborn skin increases the concern for systemic absorption of topically applied medication. Body surface area in infants and young children is another important consideration when prescribing topical agents for pediatric patients. The younger the patient, the more absorption may vary. Next, drug distribution. Distribution volumes of a medication vary with the body composition of a pediatric patient. Consider the body weight composed of fat, protein, and intracellular water. Neonates and young infants have the highest percentage of body weight in the form of water, with additional variations when considering the extracellular water volume. Considerations of extracellular and total water body weight is critical when prescribing water-soluble and lipophilic compounds. The role of plasma proteins in binding drugs also influences distribution. Albumin has the greatest binding capacity of the plasma proteins, and infants and children have lower concentrations of such proteins when compared to adults. Membrane permeability also influences the distribution of drugs to deep compartments, such as the central nervous system. This age-dependent variability is attributed to progressive increases in efflux transporter expression and function, and tight junction capacity. The primary care provider must therefore be aware of contraindicated medications during breastfeeding. Drug metabolism. The most medications are metabolized in the liver with phase 1 or phase 2 reactions, identified as major pathways involved. Maturational changes in phase 1 and phase 2 enzyme reaction are attributed to changes in drug metabolism throughout childhood, although there is a general trend of increased metabolism with age until adult levels are achieved in puberty. Genetics, comorbidities, and environmental issues also may influence metabolism. Neonates and young infants have decreased drug metabolism rates, slower clearance, and prolonged elimination half-life. It's important, therefore, that the primary care physician is aware of the enzymatic activity required for drug metabolism and monitors drug levels as indicated. And finally, drug elimination. The maturity of the pediatric patient's renal excretion system has a significant effect on drug elimination. The glomerular filtration rate in neonates is approximately only 30 to 40% that of adults. However, the adult value is usually reached by 6 to 12 months of life. In children, the glomerular filtration rate may exceed that of adults, requiring higher doses per kilogram to be effective. Common drugs cleared by the renal system, such as penicillins, gentamicin, and digoxin, require dosage and dosing schedule changes and close monitoring in ill or immature infants. Pharmaceuticals used in pediatrics, the off-label prescribing. Due to limited studies in the pediatric population and lack of pediatric labeling, off-label medication utilization for pediatric patients has continued relevance for primary care physicians, especially when they're prescribing medications for neonates, infants, and patients younger than 2 years of age. Medication approved by the U.S. Food and Drug Administration requires evidence supporting the efficacy and safety of that medication, often provided in the form of two well-controlled trials. This is difficult to achieve in pediatrics due to several factors, including relatively small pediatric populations with certain conditions, ethical considerations required when conducting pediatric research, and lack of financial incentive for pharmaceutical companies. It's important to note that prescribing medications off-label does not imply that the medication is being used inappropriately, illegally, or experimentally. Evidence for pharmaceutical use and safety in the pediatric age group may not have been submitted to the FDA, or the drug may not meet the level of substantial evidence needed for FDA approval. An example of this is many antibiotics, asthma medications, dermatologics, ophthalmologics, eye drops, asthma medications, and psychotropic drugs are effectively prescribed off label. This use does, however, require a primary care physician to consider several factors, including the evidence supporting that decision, thorough consideration of risk and benefit, and open discussion with the patient and caregiver. Two federal laws that were permanently reauthorized in 2012 increased the evaluation and labeling of drugs for infants, children, and adolescents. Those were the Best Pharmaceuticals for Children's Act and the Pediatric Research Equity Act. The BPCA provides incentives that encourages manufacturers to conduct pediatric studies and medicines that may be used in children. The PREA aimed to provide pediatric labeling for product by authorizing the FDA to require pediatric studies of certain drugs and biologies. The passage of these two acts is credited with over 800 labeling changes. A summary of these changes can be found in the Pediatric Labeling Changes spreadsheet and highlights the product indication studied, a summary of the change, medication category, and legislative type. The perils of prescribing off-label. The practice of prescribing off-label is not without risk. Providers must balance patient safety against their judgment that the patient will derive the intended benefit. Some general guidelines when prescribing off-label include the following. 1. Consult the physician's desk reference, Hippocrates, Lexicomp, or other reputable pharmacologic apps, websites, or the package insert. Refer to published literature regarding medications whenever possible. When publications are, however, not available, use other scientific evidence and expert medical judgment. Check the FDA website for any warnings about a drug. Discuss recommendations for off-label treatment with the patient or family. Document the decision-making process and patient-family consent in the health record. And again, always be mindful of the precautions that come with each drug, heeding warnings and contraindications. Other factors to consider in medication management. Decisions about which drugs to use in pediatric patients are not based simply on which will be most effective in treating the clinical condition or which drugs are most typically prescribed. Ethical considerations must be taken into account when prescribing, particularly where evidence of efficacy is weak or anecdotal and safety is a concern. Social and functional family issues must also be considered, as well as factors that influence adherence such as taste, dosing regimen, and collaborative decision making. Parental education related to medication use is discussed in Chapter 1, and the reader is encouraged to review this discussion. The developmental level and age of a pediatric patient affect the amount of influence parents have over the administration of and adherence to a medication regimen. For infants, it is important to take the following into consideration. The parent should be taught how to properly administer medicine. Determine whether the other caregivers will be administering the medicine. Determine whether a simplified dosing schedule is necessary for family. In early childhood, children begin to exert their independence, and administering medication to this age group may be a challenge. The key to success with this age group is choosing a medication regimen with the fewest problems associated with administering, such as taste and frequency. Consider palatability and doses per day, and if mixing the medication into something such as applesauce or pudding, use the smallest amount possible so that the dose can be administered in one spoon. In the middle childhood, children are developmentally industrious, and they are often more willing to take their medicine. Education should focus on the parent who will supervise and administer the medication and the patient who will be taking the medication. Letting the patient choose the formulation if possible, whether it is a liquid, a chewable, or a pill, and avoid dosing during school hours when possible. Adolescents often administer their own medicine. The provider needs to closely collaborate with adolescent patients regarding their medication regimen by allowing them to have their input about their dosing schedule and what works best for them. Assisting the family with the transition from parental supervisor to teen administrator. Medication adherence. In 2015, survey data regarding ambulatory healthcare sponsored by the Center for Disease Control and Prevention found that 70% of pediatric healthcare visits resulted in a drug being provided or prescribed. In addition, the number of chronically ill children and adolescents continued to increase as treatment modalities and survival rates improve, necessitating long-term medication use. It is estimated that about 50% of children and 65 to 90% of adolescents do not consistently adhere to their prescribed medication regimen. Non-adherence to medication and treatment regimens has several consequences, including increased healthcare utilization and cost, drug escalation, drug resistance, and treatment failure. There are many factors that contribute to the non-adherence, including several unique factors that must be considered in pediatrics. In addition to the cognitive and developmental limitation, pediatric patients who are prescribed medication regimens are vulnerable to social determinants or influences of health, including healthcare access and quality, neighborhood and built environment, and economic stability of the family. The term adherence is currently used to describe whether a patient is taking the recommended pharmaceutical or following a recommended treatment regimen. Providers need to assess the patient and or parents' barriers to medication adherence. Non-adherence needs to be proactively managed to improve clinical outcomes and cost effectiveness. Discussing general factors that contribute to low adherence rates and suggests strategies to increase those rates, a myriad of research studies about adherence have led to the following conclusion. Adherence is not a steady state. Therefore, adherence needs to be assessed as each part of the office visit. Open-ended questions that allow the patient and parent to opportunity to describe the adherence may provide more accurate information. There are several strategies for assessment of medication adherence. Self-reporting questionnaires, validated tools, and developed for caregivers and children. And structured interviews are effective strategies for measuring adherence. The use of objective measurements to determine the adherence level, including strategies such as therapeutic drug monitoring, pickup and refill rates, and medication counting during visits. Adolescents are less likely to be adherent to medication regimens in some settings. Adherence rates in this group can be increased with interventions including mobile gaming interventions, mindfulness training, praise text messages, and web-based education. Patient families benefits from ongoing interprofessional education and psychosocial support through the treatment continuum, with emphasis on strategies to promote adherence. Age-appropriate incentivization is especially effective when used in combination with other promotion strategies, such as motivational intervention, education, and technological use. A provider is more effective when practicing active listening, providing emotional support, and using plain language, giving brief but complete instructions, and having the pediatric patient and or parent repeat instructions or teach back, allowing adequate time for visits, using a wide range of teaching methods and tools, and involving office staff in teaching activities. Language barriers and health literacy impact medication adherence and errors. Strategies to overcome limited health literacy include providing verbal instructions, including pictures and other visuals, and utilizing language that can be completely understood by the patient. Incorporating all modes of teaching styles, the use and tools, and emerging technologies can be effective in providing and improving adherence rates. These tools include pictogram based instruction sheets, telephone counseling, video or mobile games to improve knowledge, disease management adherence, and clinical outcomes. Mobile phone apps, short and weekly text messages, pillboxes and organizers, hands on demonstrations, and electronic monitoring devices all record inhaler use. Written instructions increase adherence rates. Consumer medication information leaflets dispensed through retail pharmacies are intended to be short and comprehensive. They're written by a third party drug information company and are not FDA approved or regulated. Patient package inserts are developed by the pharmaceutical manufacturer and discuss risk information. They are lengthy, detailed, and intended for the use of the medical provider. Establishing a provider pharmacist collaborative management program may also improve adherence rates. And lastly, providers should self critique treatment biases they have towards ethnic, ethnically and socially diverse populations and overcome any cultural benefit barriers. Coming back up real quick, here is an excellent spot to hit pause to see the factors that may influence the adherence to taking prescribed medications in a pediatric patient. So it's a good spot to hit pause. I'm going to just hit the key bullet points here: length of treatment, medical condition, doses per day, palatability, expense, belief system, and social determinants. Again, pause please to read the whole thing. I just hit the bullet points here. So, that brings us to the disposal of pharmaceuticals. The preferred method of medication disposal is through a drug take-back program, which is available in communities across the nation. If families are not able to access a take-back program, there are safe ways to dispose of some medications at home. The FDA developed a flush list of medications that can be flushed down the toilet, although there is concern about the environmental and human health risk associated with flushing medications down a toilet. The FDA determined that the risk of accidental exposure to such medications far outweighs the potential risk. For medications that are not on the flush list, however, disposal in home trash requires a process described by the FDA. Medicine should be mixed with coffee grounds, cat litter, or another undesirable substance before being sealed in a container that is thrown in the trash. Advise families to remove all personal information from the med packaging. In addition, the Drug Enforcement Agency has information regarding prescription take-back days and authorized collectors on their website. Overprescribing antibiotics, which is a continuing problem. About 2.8 million illnesses and 35,000 deaths in the US are attributed to an antimicrobial resistant infection each year. In response to the serious public health threat, a national action plan for combating antibiotic resistant bacteria was developed back in 2015. The current plan describes a coordinated strategic plan to reduce infections and antibiotic use from 2020 to 2025. Five goals were identified with several objectives for each, including improved outpatient antibiotic use, support for healthcare providers to promote recommended antibiotic use practice, and support for policies to improve antibiotic use across the healthcare setting. The most prescribed class of medications in pediatrics are antibiotics, and the majority of these are prescribed in the outpatient setting, so clinics, ERs, urgent care centers, telehealth appointments, and other venues. An estimated 30% of prescribed antibiotics, however, are unnecessary. The most common antibiotic misuse indication is acute upper respiratory infections, including acute otitis media and pharyngitis. There is also evidence that patients who receive an antibiotic during their first episode of bronchitis are more likely to have a second episode of bronchitis and to receive another antibiotic than those who did not get the antibiotic prescription during their initial episode. This data supports the need for antimicrobial stewardship programs. The goal of pediatric antimicrobial stewardship programs include using antibiotics appropriately, at correct doses and duration, as well as limiting the spectrum of antibiotics to the infection being treated. Strategies to achieve these goals include clinician education, standardized protocols, improved family communication, clinical decision support, and systematic approaches to situations such as negative culture results. Antibiograms support PCPs' decision making and promote the selection of the antibiotic with known effectiveness in the geographic area of the prescriber. Diagnostic stewardship further supports antimicrobial stewardship by requiring characteristic findings of various infections before prescribing antibiotics. Antimicrobial stewardship programs are proven to be effective, and the collaboration between the government providing healthcare facilities and the community outlined in the National Action Plan has the potential to decrease the threat of antimicrobial resistance. So, guidelines for writing a prescription. Before prescribing a medication, the primary care physician must take several critical steps to ensure the prescription is appropriate and rational. Make a specific diagnosis, consider pathophysiologic implications, and identify a therapeutic objective. Once all those steps are complete, identifying the appropriate drug, considering the appropriate dosing regimen, plan for monitoring, identify an endpoint, and share the information with the patient and caregiver. Write prescriptions in a manner that conveys accurate information to the pharmacist, the patient, the parent, and other clinicians accessing the patient's chart. Prescriptions include information regarding the prescriber, including the name, license, and contact info, and the patient, including name, address, often the date of birth. The body of the prescription includes information regarding the medication prescribed. The specific medication brand name or generic prescribed is the first element. This includes the medication name and strength and metric units. The quantity to be dispensed should reflect the anticipated therapy duration. This may not this may be enough for a 7-day treatment course, such as the case as an antibiotic for a bacterial infection, or a 1 month or 90-day supply for ongoing treatment of chronic conditions. Primary care providers must also consider if there is a risk of an overdose or toxicity associated with dispensing larger amounts of prolonged courses of the medication. Next, provide complete direction for use, including the medication amount, administration route, dosing frequency, and duration of therapy. The number of refills provided is guided by the anticipated therapy duration and consideration of whether or not effectiveness is established. Initiating a new medication for a chronic illness that requires reassessment before refilling the second dosing. Prescription errors are a common threat to patient safety. Across the continuum of care, among the most common errors in prescriptions are dose or timing errors related to poor writing, omitted information, and inappropriate medication choice for specific situations. Online resources are available to help reduce or document prescribing errors, including the Institute for Safe Medication Practices and National Coordinating Council for Medication Error Reporting and Prevention Program. Electronic prescribing led to several changes in prescribing practice, and an estimated 70% of prescriptions are now e-prescribed in the US. While this presents an opportunity for primary care physicians to gain information from the health plan regarding formulary decision support regarding potential interactions and more effective transactions between prescribers and pharmacies, it does present a new challenge. Prescription errors due to pull-down drug lists contribute to other unique factors to electronic prescribing are common. Enhance prescribe accuracy by following the guidelines listed in box 23.1. Complementary and integrative therapies. Families of pediatric patients are increasingly interested in complementary and integrative therapies, requiring the primary care provider to be knowledgeable and aware of reliable resources to provide the safe and effective application of desired therapies. Common indications for complementary therapies include back or neck pain, head or chest colds, musculoskeletal conditions, anxiety or stress, and attentional deficit hyperactivity disorder. Increased utilization with children and youth living with chronic illnesses has been reported. The National Center for Complementary and Integrative Health defines complementary health as the use of a non-mainstream approach used together with conventional medicine. Integrative health is a coordinated combination of conventional and complementary approaches with an emphasis on the care of the whole person. It's important to differentiate these models from alternative health, which is the application of the non-mainstream approach in the place of conventional medicine or the use of therapies that are not evidence-based in place of conventional care. The NCCIH is a center of the National Institute of Health with the mission of defining the usefulness and safety of complementary and integrative interventions through rigorous scientific investigation. Objectives of the NCCIH include the advancement of fundamental science and methods, improved care for hard to manage symptoms, health promotion, and disease prevention, enhanced research regarding complementary and integrative health, and dissemination of evidence-based information. Subgroups of complementary health are described by their primary therapeutic input, including nutrition, psychological, physical, and combinations thereof. Going back up here, there is an excellent spot to hit pause so that you can see the guidelines of accurate prescribing. I won't read it to you, so go ahead and hit pause. Here's also another good spot to hit pause. It is box 32 or 23.2. Key guidelines for the use of herbal and dietary supplements. Again, go ahead and read that. I will not be reading it. Patient-provider communication regarding the use of complementary medicine. The topic of complementary medicine use must be broached non-judgmentally to encourage disclosure, help the family clarify safety issues, and explore how complementary therapies might fit into a patient's management plan. Non-disclosure may be related to fear of the primary care's disapproval, inadequate time, failure of the PCP to ask about such therapies, and a belief that complementary medicine was safe. On the contrary, reasons for disclosure include concerns about safety, desire for additional information, and a belief that the PCP would be supportive of their use of complementary medicine. Some questions that may support the PCP to inquire about the use of complementary medicine should include what complementary medicine products the patient is taking, which would include herbal, natural, or nutritional supplements, what complementary medicine therapies are being used, such as acupuncture, chiropractic, or massages, what other practitioners the child might be seeing, what other kinds of activities are being used to address this particular problem, and finally, has the complementary treatment helped the problem? Consistently incorporating questions about complementary medicine helps facilitate an open and honest dialogue between the PCP and the patient and family. Conveying respect for the family's values and beliefs supports their disclosure. When a PCP identifies that a patient is receiving complementary or integrative therapies, they can share evidence based info and effectively monitor treatment response. Safety considerations of complementary and integrative medicine. It is particularly important to ascertain the safety of certain treatment modalities by learning about the complementary products that the patient may be using, including the side effects, possible interactions with other medications, and the mechanisms of action. Unlike conventional pharmaceuticals, the FDA does not approve dietary supplements before they are marketed. Rather than providing evidence to the FDA to substantiate safety, the manufacturer submits a notification to the FDA with information that supports their belief that the supplement is expected to be safe. To evaluate for interactions between natural health products and medications, PCPs may refer to the Natural Medicines Database, NCCIH Herb Drug Interactions Clinical Digest for clinicians or other trusted pharmacologic resources. It is critical to refer to an interaction checked each time a PCP learns that a patient utilizes a complementary therapy, as information in this field continues to evolve. Guidelines to support the PCP's advice about the herbal and dietary supplements were described in that box 23.2. The last section here, again, as always, are the additional resources available to us. The Clinical Pharmacogenetics Implementation Consortium Guide, Drug Enforcement Agency, the Disposal of Pharmaceuticals, European Medicine Agency, the FDA, Current and Resolved Drug Shortages, the FDA, Disposal of Pharmaceuticals, FDA's MedWatch, such as the Safety Information and Adverse Event Reporting Program, the FDA's Pediatric Labeling Changes, the Institute for Safe Medication Practices, Joint Commission National Patient Safety Goals, National Association of Boards of Pharmacy, National Coordinating Council for Medication Error Reporting and Prevention, National Center for Complementary and Integrative Health, Natural Medicines, and lastly, the National Center for Complementary and Integrative Health. Herb-drug interactions. So this is where I'll leave you for the time being. We'll see you at the next chapter, and I thank you as always for listening.